So this stuff has been used in Europe for over 25 years. This leads to one of my, a little joke that I like. So, you know, people talk about, oh my God, why is the US so far behind in, like, you know, with using drugs and different technologies? And it's like the Europeans seem like they're light years ahead, right? So one, you know, this little joke is, well, what does the FDA call its lab rats? Europeans. They just wait for Europe to do all this stuff, and then the FDA says, okay, it worked in Europe for 20 years, okay, I guess we're okay with doing it now. Technology has improved very rapidly over the last 10 to 15 years in terms of resolution and power and all of that with the ultrasound. So it is actually a very, very useful machine now. Here's an example of the ultrasound probe here and an injection using ultrasound guidance for the plantar fascia right there. Okay, so what are some of the pros and cons of ultrasound? It is the modality of choice for a lot of tendon injuries. MRI, everybody thinks MRI, right? Okay, $1,500, $2,000 per study. You can do an ultrasound for like 200 bucks. The resolution is actually 3 times better than MRI, and so with certain things like tendon injuries, rotator cuff injuries, MCL injuries in the knee, plantar fasciitis, it is superior to MRI in terms of resolution and diagnostics. No radiation, right? You don't have to sit in a big magnet either like you do have to with an MRI. You can examine the patient while they're moving. So for example, if I'm trying to find an impingement syndrome in the shoulder, I can stick that ultrasound probe on there and watch their shoulder joint move while I'm doing the ultrasound and see, okay, is it pinching on any tendons in there? And you can use it to guide treatment. When it's used to guide injections, such as in this situation here, you can guide it with an accuracy of about 0.2 millimeters. 0.2 millimeters. It's literally like splitting hairs. Yeah, pretty much actually. You can split hairs with this thing. It's relatively inexpensive. All right, so what are some of the drawbacks of using ultrasound? Well, the main thing is you cannot penetrate bone. All right, so the sound waves, it's like sonar or radar. It will bounce off that bony surface, so you cannot see inside a joint. That's where MRI, CT scan, and such have distinct advantages in that you can see all the stuff that's going on inside the joint. You can't see inside the joint with the ultrasound. You can see everything outside the joint and around the joint in terms of the bursa and the ligaments and the tendons and all that stuff, but you can't really see like cartilage and stuff like that. Long learning curve for doctors who are doing this. Takes a long time to learn how to use this thing, and it's very operator dependent. You know, one person, you know, just because 2 people do ultrasound, there can be a huge difference in their skill level. And the image is very angle sensitive. If you change the angle of your probe as little as 3 degrees, it can significantly change the quality of your image. And so you have to have somebody who has a really steady hand. I would actually argue that you have to have a steadier hand doing ultrasound than doing most surgery. You know, because I've you know, done surgery in my training and stuff like that. And I'm not going to scare all of you, but sometimes you don't have to be that gentle with the tissue. I mean, these surgeons are in there, and especially the ortho guys are doing a knee replacement. They're hammering rods down people's bones and all this kind of stuff. So I like this whole phrase of, oh, you have to have hands that are as steady as a surgeon. Well, depending on what surgeon you're talking about, you really don't have to be that steady. But for this ultrasound stuff, man, I mean, sometimes I'm moving the probe like that much, you know, like a couple millimeters to get the perfect image before I do something. Question? Yes. The question is, can you do ultrasound on the back? You can, but there are limitations. Actually, one other disadvantage of the ultrasound is that the deeper you go, the worse the resolution. So because spine structures tend to be more deep, your resolution is not as good. You can still use it, but it's not as good as X-ray and MRI. It depends. Depends on the individual. Thinner individuals, I can actually see the facet joints pretty clearly, and I can do facet injections with no problem. But, you know, thicker individuals, it's pretty tough. That's for small structures in the back. Now, a hip joint, big structure, no problem. I can do a hip injection on somebody who's 300 pounds, and it's no problem. Mounted on a tripod. Yeah. You know, I've thought about that actually. I might actually still do that. Sometimes the thing is when you're examining a patient in real time, you know, if the patient like moves a little bit or something like that, it takes a lot of time to make that little adjustment and lock in the probe. So yeah, so a lot of times, you know, just holding the probe and making sure that I'm steady on the patient, that's good enough. You know, so as long as I don't have to do it 10 hours a day, you know, I can do it fine, no problem. So sometimes my hand get a little tired after a long day. Another question, yes?
Now these therapies, like the PRP and ultrasound,
sure.
When you use it, is it like you use it and then you never have to come back
Yes, this is great. I always get the same questions, and so I wait for people to ask the questions. So yes, one of the issues is, okay, well, how often do you need treatments, how many treatments, and all that. To answer your question most directly, if the injury is from not a genetic process like osteoarthritis, and it is from like a tissue injury, and the treatment actually works, because it doesn't work in 100% of individuals. If it works, it is permanent. It is permanent. So let's say somebody has a traumatic rotator cuff tear, you put PRP in there and it fixes that thing, it's fixed permanently, right? Problem is with things like arthritis, where it's a chronic degenerative genetically related process, that arthritis keeps coming back. And so you can repair the damage that the arthritis causes, but the process of the arthritis cannot be stopped. So a lot of times in folks with arthritis, they have to come back for sort of like booster injections every couple of years kind of thing to keep them on track. Number of treatments. The PRP is, which actually I've got a final slide on this at the end, is more powerful than the prolotherapy, so you need fewer treatments. Generally speaking, 2 to 4 PRP treatments will fix people up. With prolotherapy, you need more like 5 to 7 treatments. Obviously, that's, you know, it's a bell curve. Some people you only need a couple of prolotherapy treatments. Other people you need 10 or 12 or 14 treatments, especially if they're hypermobile. So there's that range there. And the treatments are separated in time by 3 to 6 weeks. So every 3 to 6 weeks you have a treatment. So, you know, this is not a quick fix. We're getting your body to heal itself, and it's a slow process. So it takes weeks and months for this, actually months really, for the process to, you know, to really be completed. Good news is when it works, your pain decreases that whole period of time gradually. So it's not like you got to wait 6 months before you feel any improvement. You'll hopefully feel improvement within a couple of weeks, and it just gradually gets better, better, better.